Greetings, everyone. The title of my paper is Measuring What Matters, Developing Contextually Appropriate Metrics for Artificial Intelligence Impact in Nigerian Healthcare Delivery. Let me start with a provocation. We have all seen the headlines. Artificial intelligence detects pneumonia with 99% accuracy. Deep learning beats radiologists. New algorithm achieves AUC of 0.9%, 95%. These numbers dominate conferences, journals, and funding proposals. They come from computer science, clinical epidemiology, and they're beautiful if you are a researcher in a high income setting. But here's my question. What do these metrics mean for a mother in a rural primary care center in a place like Kano State, Nigeria? The answer is, I will argue today, is very little because an artificial intelligence model with perfect accuracy is clinically useless if it requires high bandwidth internet in a facility without electricity. It provides no benefits if it recommends referrals that patients cannot afford, and if it's to make it even worse in equity, if it's deployed only in urban teaching hospitals, diverting scarce resource from primary care. So here is the core problem my study addresses. We are using first word metrics to evaluate AI in resource-constrained settings, and that is an equity failure, not just a technical oversight. Nigeria exemplifies this mismatch. We have over 30,000 primary care centers, many without reliable power internet. 70% of health spending is out of pocket. Patients ask, will this app AI really help me get care? Will it reduce what I pay? Will it reach my village? But our evaluation framework asks, what is the AUC? So my study set out to do four things. Identify the gap. And what I mean is to be able to establish the gap between existing metrics and what Nigerian stakeholders actually care about. Number two is to develop a consensus framework or consensus-driven contextually appropriate metrics framework. All right. And to also conduct a field test that that has a framework in real artificial intelligence pilots across Nigeria. And lastly, to produce a practical toolkit for policymakers, implementers, and founders. So we used a three-stage mixed method design. The first stage is a systemic scoping review of artificial intelligence evaluation metrics in LMIC healthcare. This comprised about 47 papers, which we used. And stage two was now to modify Delphi consensus process with 32 Nigerian stakeholders. This included policymakers, clinicians, health economists, patients, and AI developers and implementation managers. At the stage three, we did a field testing in three real-world AI pilots across Nigerian three healthcare tiers, primary, secondary, and tertiary, over a period of about 12 months. And here is what we found in the scoping review. Across the entire 47 studies that was conducted, we realized about 89% reported technical accuracy in primary outcome. Only 23% reported any access-related metrics. 13% reported cost or financial impact, and only 6% reported equity stratified outcomes. Zero studies used a balanced framework that prioritizes access, cost, and equity alongside accuracy. This is not a critique of individual researchers. This is a critique of our field's default assumptions. So we went to Nigerian stakeholders and asked, what actually matters to you? We conducted three rounds of Delphi. Round one was open-ended. We conducted 47 unique outcomes suggestion. Round two, we rated 28 candidate metrics on importance and feasibility. Round three, we re-rated after seeing group feedback. So consensus was defined as at least 97% of participants rating, an item of 7 to 9 on a 9-point scale, and 0 than 15% rating on a 1 to 3 scale. The result is what we call HEART framework, which stands for Health, Equity, Access Reward Tracking. HEART framework. It stands for Health, Equity, Access Reward Tracking. It contains just 12 metrics across four domains. Domain one is access, which is the coverage reach, wait time reduction, and referral completion. The financial impact, patient out-of-pocket reduction, facility cost by income, catastrophic expenditure averted. And the third is equity, rural urban penetration ratio, poorest quantile penetration, gender parity index. Fourth is clinical implementation, tax shifting efficiency, clinical trust, negative event rate. So I want to pause here. None of these metrics are about raw accuracy because accuracy, as one stakeholder told me, is the price of entry, not definition of success. Now, we conducted three pilots in our field testing. Uh, the pilot A is the usage of a USSD-based material triage tool in 10 primary healthcare centers in Kano. Pilot B was an offline chest X-ray artificial intelligence for tuberculosis triage in 5 secondary hospitals in Enugu. And Pilot C is a clinical documentation artificial intelligence in two tertiary hospitals in Lagos. So we collected data on all 12 metrics using facility logs, patient exit interviews, staff surveys, and financial data. Here is our first critical insight. In Pilot B, the chest X-ray AI adds excellent technical performance of about 91% sensitivity and 89% specificity. Okay, but look at the heart metrics, coverage rate. Only 34% of eligible patients actually received an X-ray. The AI cannot help those who never present. Referral completion, we had about 58% of AI suggested TB suspect completed confirming testing because of uh, 3,500 cost barrier. And equity, rural patients were 60% less likely to receive an AI-assisted X-ray than urban patients. So a policymaker relying only on accuracy would have celebrated. But a policymaker using heart would have identified critical implementation gaps. Second insight was on financial impact is there specific. In pilot a rural maternal triage, which is patients who pay out of pocket, dropped by an average of about 8,200 naira per episode. That is 3 days' wages for median patients, which is quite important. In Pilot C, a tertiary documentation AI, patient costs did not change at all, but clinicians' time savings were substantial, which is about 47% minutes per doctor per day. That is significant. The lesson three, which is the value is not only one size fits all that counts. Success in a rural primary care center is different from an urban teaching hospital. The third insight, and this is the one that keeps me up at night. In Pilot A, the maternal triage artificial intelligence was designed to reduce referral delays, but our equity metrics showed that uptake among the poorest women was only 28% compared to 67% among wealthier women. Why? The poorest women could not afford 15 naira to send an SMS message less than 1 cent. But for a patient living on less than $1 a day, that's a barrier. We now decided to make the USSD service for free. And there was a reverse. The poorest quantile penetration rose to about 71% within 2 months. These equity critical adjustments would never have been identified without disaggregated metrics. Now, you might be thinking, these metrics sound great, but are they feasible in a low resource setting? We tested that as well. Of the 12 metrics, we collected about 80% completeness or higher in at least two pilots. The two challenging metrics were catastrophic expenditure averted, which required, of course, detailed household surveys, feasible for research, not routine monitoring. We recommend sampling for this. Referral completion, which required phone follow-up, Loss to follow-up was 32% in one of the pilot that we did. And overall art metrics are feasible, not free, not easy, not possible. So we built a practical toolkit, which is available as supplementary material. For resource-constrained implementers, we recommend a minimum viable metrics, a subset of 6: wait time reduction, patient out-of-pocket reduction, forest quanta penetration, tax shifting efficiency, clinical trust, and negative event rate. So we also propose tier-specific weighing at primary health centers. Access and financial protection dominates 70% of the evaluation score. At tertiary centers, clinical implementation and trust matter more. About 55% of those made up the score. How does HART compare to existing frameworks? So Consult AI and Spirit AI are rigorous but assume high resource trial settings. WHO's AI for health guidance is high level but not operationalized in measurable metrics. That is different, empirically derived from Nigerian stakeholders, field tested, and equity centered and test specific. No, let me be upfront about limitations because that is very important. First, field testing was only done between the period of 6 to 12 months. So we don't know about longer term dynamics like trust decay or equity drift. Second, our Delphi panel underrepresented very remote nomadic populations like the Fulani pastoralists. Third, cost data required assumptions about staff time attribution. And fourth, artificial intelligence evolves rapidly. Metrics like task shift efficiency may need recalibration. But the core finding stands: current metrics are insufficient and contextually appropriate alternatives are both necessary and feasible. For Nigerian policymakers, it's important to mandate that all publicly funded AI tools report art metrics as a condition of procurement, integrate them into national health information system. For founders and developer partners, tie disbursement to performance on access and equity metrics, not just technical milestones. Fund the data infrastructure needed to collect these metrics. For researchers, validate art in other LMIC settings like Ethiopia, India, Bangladesh. It's important to develop lighter methods for catastrophic expenditure measurement. Let me close with this. The question: does this AI work? Is fundamentally different in a Nigerian primary care center than in a Massachusetts teaching hospital. Yet the metrics we use to answer it have been nearly identical: accuracy, sensitivity, AUC. That is not just a technical oversight, it's an equity failure. The HART framework offers an alternative, a 12 metric balance scorecard that centers what actually matters to Nigerian patients and policymakers. Did the AI help people access care? Did they reduce what they paid? Did they reach the poorest and most marginalized? Field testing shows that heart metrics are feasible, reveal crucial blind spots, and can drive real-time course correction. As Nigeria and other LMIC scale AI healthcare, the choice is clear: continue measuring what is easy or start measuring what matters. Hard points the way. Thank you very much. That's all I have on this paper presentation. You can reach me via mail displayed on the screen, and I encourage you to subscribe to my channel so be notified when I post a new paper publication.